I had asked, I was at the UC Health Conference recently here in the Springs, and I was visiting with Scott Lynn with GMR, about a topic I have been trying to get presented at this conference, because I did a survey of rural frontier services here in Colorado, asking them numerous questions. And one of them was, who's your billing service? And out of the 42 different agencies I spoke to, there were 30 different billing services. And I find that troubling, because I am just positive they aren't all doing a good job, and yet those agencies have no idea whether they're doing a good job or not. And so my goal was to have somebody speak to what you should be looking for in your billing documents, and what your accounts receivable, things like that should be. So Jen is with GMR. She's the National Revenue Cycle Director. So Jen, welcome aboard and enlighten me.
All right. Well, I have to laugh because I'm having very strange video problems. So I look invisible right now, which is probably what you guys were hoping for, since it's the end of your conference and, it's the very end of the day on a Friday, and you guys have been sitting there for a while. So I'm sure that the last thing you want to talk about is billing. So it's going to be fun and exciting, but I'm going to stop sharing my video because you can't see me anyway.
That's good. That's fine.
So can you guys see my screen, or no? Do I need to reshare?
Oh, you're just fine.
Okay. So as Kim said, I work for AMR and I'm the National Revenue Cycle Director. My job is pretty unique because I get to look at things from the time somebody calls for our services all the way through until those services are paid for. So it's kind of a nice, I guess, position to be in. I am a medic. I've been in the business for 31 years, and I like to be in this position because I can see things from the operational side, which I'm used to, and then obviously the clinical side, and now I've learned the billing side as well. Many people have said I've come to the dark side with the billing piece, and I would venture to say that you guys probably think the same. But the reality is we have to have billing. So we have to figure out how to do it and what we're looking for and how to make sure that we're getting the bang for our buck, since we're providing services out there. So the objective of the discussion today will really be to review the life of an ambulance trip. Again, that time from the call for service until those services are paid for. We're going to look at that situation and what we want to look for to make sure that those services are paid for in the end. And then we'll review the metrics that you guys should be monitoring as it relates to ambulance billing, because there are a few things that you have to pick up on and you have to just kind of keep a close eye on. So you can make sure those services are being paid for. So the agenda, will talk about quality clinical documentation. Then we're going to talk about what happens once the trip is transmitted. And then we'll look at what to look for after the trip is billed. So let's start with quality clinical documentation. The reality is that quality clinical documentation is quality billing documentation. And I think that because most of us from a field perspective just want to take care of the patient, sometimes it's hard for us to understand the billing piece of it on the back end, because that's not what we've got in the business for. But the key to solid ambulance billing is to actually have accurate and robust clinical documentation of the patient care record. The crews really do need to feel that what they're writing down is what services they provided for the patient. They are the ones that are with the patient. They are the ones that know what's going on with the patient. And we really need to make sure that we've got that quality clinical information in the PCR, because that's how billing is going to know what to bill for and how to do the billing. So obviously our crew should be caring for the patient, but the crew and the documentation of the clinical event lead to solid billing and reimbursement. So if nothing else comes out of this presentation today, just remember that quality clinical documentation is quality billing documentation. One other thing to think about, as none of us want to think about, is the fact that the PCR is looked at for many other things than billing. It covers you in situations where your PCR is pulled for other reasons, like audits, which there are tons of audits out there that on the front end you don't know about, you don't really think about, but on the back end, a whole lot of work is going into the audits. Medicare does audits, other payers do audits, It happens all the time, and you would never know as the front end provider how many times that PCR is being touched, but it's a lot. So it's going to cover you. Good quality clinical documentation will cover you in audits for legal purposes. Patients request their documentation all the time. They want to see their patient care record. Trauma registries need the patient care record. So there are a lot of other people out there besides the provider and whoever's doing the clinical quality review within your service that are going to be looking at all of those PCRs that are coming through. So I'm going to reiterate, clinical documentation is billing documentation. So both need to be quality. Quality clinical documentation is quality billing documentation. So when you're looking at the clinical documentation, to make it quality billing documentation, you have to look at the three big things: demographics, clinical information, and signatures. Now, demographics are interesting because there are a whole lot of people out there with the same name. So I always tell people it's really important to get the patient's full name, including middle initial if you can. Make sure it's spelled right, because that's how you're going to make sure it's the right patient. And then the other piece of it too is getting some of those indicators that might help us identify who the patient is. And so making sure that you have a phone number, making sure that you have their mailing address. Are you able to get a social security number? Social is one of the things that most people are most hesitant about asking for. And frankly, most of our patients have no desire to give out their social security number. But the reality is that is the one number who identifies the person as that person. Not talking about identity theft or anything along those lines. But if you have their social, you know that that person is that person. Phone numbers and email addresses nowadays really improve contact with your patients so they can engage with the billing company. It's really helpful when a patient who is used to texting may get a text from the billing company saying, hey, we noticed that you had a trip and we don't have insurance on file. If you have insurance, please call us, or whatever the scenario is. So it's good to have that additional information for good quality engagement with your patients. But make sure your demographics are as complete as possible, because that's going to help improve the time to bill and ultimately no hassle for your patients. I always say that patient advocacy goes way further than just dropping your patient off at the destination. Patient advocacy is actually good, solid documentation, as well as all the way through the billing process. If you've got a billing company who is not very friendly, has poor customer service, that's going to reflect on you guys. So we don't want to give any reason for any of our billers, whether it's internal or a third-party vendor. We want to make sure that we can provide them with as much information as possible so the patient doesn't have to get involved with that. So it's, again, it's really important to get good demographic information. I do always tell the story about the fact that, my name is Jennifer Jones, not a very common name. I mean, most people in the 70s weren't named Jennifer if they were a female. I mean, there's only one or two of us out there. Yeah, there's a whole bunch. In fact, in my family alone, there are 3 of us. So obviously I'm married into the Jennifer Jones world, but my sister-in-law was Jennifer Jones, and my other sister-in-law who married into the family is also Jennifer Jones. The really messed up part of it is the one that was the original Jennifer Jones used to live a block and a half away from us. So there was really, and of course, everybody with the name Jennifer, middle name is always going to start with an L. So you've got people, my family alone, with 3 people with the exact same name. How in the world do you identify who's who? And so that's why it's important, again, to try to get that social security number. Patients aren't real confident saying, hey, yeah, my social is this. But if you explain to them why you need it, it usually goes a long way. You're going to have a rapport with the patient while you're in the back of the ambulance. And so you're going to be able to just advise them, hey, this is why I need it. It's so we can identify that it is you, so we can go ahead and bill any insurance that you may have. You don't have to get involved in the hassle of working through the insurance. And we just need to prove that it's you that we transported. And if you can provide that information to them, it's really helpful. As it relates to clinical information, you want to know why in the world the ambulance was called in the first place. So the clinical information is an absolute must, and you need to know what the patient's situation was, Why did they call for an ambulance? And then you need to assess your patient from head to toe. Clear documentation of everything that is found is really important. Like I said earlier, quality clinical documentation is quality billing documentation. Having all of that information in the PCR is important, and don't skimp on it. Make sure you've actually added all of that information in there so that you have a good solid PCR. Make sure you document every little thing. When you skimp on things though, that's when you leave gaps in your documentation. That's when we run into problems. So clinical documentation is critical because that chart is the legal document that is used for, as we talked about a little while ago, a ton of different things. Many people are going to look at your PCR. So have that quality documentation in there so you don't have problems. People aren't questioning things. You don't have concerns about how you treated your patient. It's just important. And I'm totally preaching to the choir here. I know I am, but quality clinical documentation will be quality billing documentation. Then you get into the signature piece of things. The signatures are really important. Not only does the crew need to sign that legal document, and they're signing it to attest to the findings and the care provided, but the patient needs to sign acknowledging we transported the patient to the destination. So we need to make sure that we're getting the gold standard, which is the patient's signature. But kind of like social security numbers, patient signatures can sometimes be hard to get. One of those things that we run into, of course, are the patients who are unable to sign. So when the patient's unable to sign, then you can get a patient representative signature. And the representative basically is a patient's legal guardian or a relative or other person who receives governmental benefits on the patient's behalf, or a relative or other person who arranges patient's treatment or manages the patient's affairs. So those are the three people who can sign as a patient representative if the patient is unable to sign. If your patient can't sign, you need to have good documentation as to why they can't sign. If they're unconscious, then it's pretty clear in your PCR that you have an unconscious patient, and it would explain why you couldn't get their signature. But if the patient is awake and talking to you and everything's looking good and you didn't get a signature, you may run into trouble. Some of that trouble includes not being able to get Medicare. We can't bill Medicare without a patient signature or a representative signature for that matter. And usually you can't bill an insurance either. And the reason for that is the patient's contract is with their payer, with their benefit provider. That's who has the agreement. They're the ones that are in agreement with the insurance company that provides benefits on their behalf. The ambulance company doesn't have that contract with that payer. So we have to get the signature from the patient saying, hey, yep, I'm allowing AMR or, whoever, whichever ambulance provider, I'm allowing them to bill on my behalf. So as I mentioned, the patient signature is really important. And if we don't get the patient signature, we have to attempt to get it after the fact. So if the crew didn't get the signature, they didn't get a representative signature, then the crew can sign, but they also need to have somebody at the destination sign as well. And the person at the destination is signing just attesting to the fact that somebody was transported to their facility. So when you get a representative signature, unable to get one, unable to get a patient signature, then you get the facility signature saying, yes, Jennifer Jones was transported to Penrose, and then we're good to go. But there's still going to be a signature sheet that's going to get sent out to the patient after the fact. Basically, again, as we've talked about, the patient signature really is that gold standard. That's who you want to sign the PCR. But if you can't get them to sign the PCR for whatever reason, please make sure there's good, solid documentation in the PCR that points out why the patient couldn't sign. Again, they're the people, they're the patient. The patient has the relationship with the payer, and we don't, as the ambulance provider, we don't have that relationship. So the patient needs to indicate whether or not we can bill on their behalf. I'm rolling through these pretty fast. So Kim, if there are any questions, just let me know.
I think we're good. Go ahead.
Okay. So once the PCR is written and done, which is also known as being posted, transmitted, or submitted, depending on which ePCR platform you use, once it's done, it gets sent off to billing. The next steps are the billing piece, responding to audits, possibly providing legal, if there's a legal need for it, providing the PCR for any of those situations like subpoenas, and knowing that the PCR is an important document. So once it's been transmitted, it goes to billing. When the PCR goes to billing, the revenue stream really starts. That's when it all begins. The ambulance coder will review the PCR. Now, a coder may or may not have any medical experience. I know on our side, we have a third-party vendor, and our ambulance coders with the third-party vendor are not clinicians. So it's really important to make sure that the clinical documentation, again, is quality. We need to have quality clinical documentation for quality billing. So making sure that the coder can read through that PCR and understand what's going on is going to be really important. They're going to review the PCR, and then based on the care within the PCR, they determine the level of service that should be billed. So on the ground ambulance side, there are 4 levels of service out there. There's a BLS, or basic life support. There's an ALS 1, and there's an ALS 2, and then there's SCT. The difference between ALS 1 and ALS 2 really does pertain to the back end billing side of the fence. For the crews, it doesn't matter. There's not going to be anything there that they need to differentiate for. But just so you guys are aware, ALS 2 is a kind of a handful of procedures that allow for an ALS 2 level of service to be charged based on the fact that, for example, intubation was performed, or an IO was placed, or cardioversion was done, or 3 different medications were administered via IV for 1 patient. So those are usually ALS 2, and essentially the base rate, which is the base amount that you would charge given whatever that level of service is. The ALS 2 base rate, because of the criticality of the patient, is usually a little bit higher than the ALS 1 level. So the level of service that's billed depends on the care provided. And there's an interesting thing called the ALS assessment. Now, Kim, I can't really see what's going on, but I'd love you guys to raise your hand if you know about the ALS assessment. I see a few hands raised. Ugh, ALS assessment. I don't know about you guys, but it's exhausting. It's just a difficult thing to really deal with. So the whole point of the ALS assessment, probably 20 years ago or so, Medicare said, hey, you know what? You guys, there's a cost of readiness to have you guys out there waiting for a 911 call and then responding to it and caring for your patient. So because of that cost of readiness, we're going to go ahead and say, hey, if you respond to a call that you think is going to be ALS, and you have an ALS provider on that unit, and that ALS provider does an ALS assessment, then you guys can actually charge a little bit more because of that cost of readiness. So the situation really is, it's based on 3 different things. 1, the fact that the call that we received was an ALS nature of call. So for example, chest pain. And then 2, we responded with an ALS provider. And then 3, we have that documentation that the ALS provider documented an ALS assessment. When all of those things come together, then the ALS assessment can be charged. But the problem that we run into is people don't always know when they're supposed to do an ALS assessment. So I feel pretty strongly that when you're an ALS provider, you don't turn off your ALS brain. There are some days where I feel like my brain is off, but usually when you get on scene with a patient, you're going to be assessing that patient. And so because an ALS provider is sitting there saying, okay, let me see what's going on, there may be an opportunity for a documentation of an ALS assessment, but you need to make sure that it is performed and it is appropriate. The other thing that our crews don't often think about is, whether or not that nature of call is ALS. They're not worried about that. They're just responding to the call. So the things to consider on the back end, and this comes into the billing department's world, they have to look at whether or not that determinant code, the MPDS code, the EMD code that's coming from dispatch, whether or not that code is an ALS code. So if you have a patient with chest pain and the paramedic responds and the crew does an assessment of the patient and determines that it's I don't know, it's a little bump on his chest. Nothing cardiac related at all. And so the EMT attends while we transport the patient to the hospital. Does that count as an ALS billed trip? Because there was an ALS assessment done and it was an ALS EMD code. Well, no, it doesn't count. In that case, you would have the ALS assessment that would come into play, but there would only be BLS care that is being provided. So the ALS assessment comes into play, but the ALS level of service, that base rate alone would not necessarily be the case. So I guess one thing, this is where ALS assessment gets crazy, because it does allow you the opportunity for an ALS charge if it's done appropriately and correctly, but it's not always the driving factor in the level of service. So you just need to make sure that there's some good quality documentation of what's going on. And then the coder on the back end is going to understand all of these different components to determine whether or not that should be billed at whichever level of service. ALS.
Yeah.
Oh, go ahead.
Just a quick question from me.
Uh-huh.
Did I hear earlier today him say that if the dispatch said it was ALS, the provider was ALS, and an ALS assessment was done, but it was determined to be a BLS call, since all three were met, they could bill it ALS?
That is what my assumption was as well.
That is from an ALS assessment charge, and it all depends on how your system is set up. And what I mean by that is in some markets, there's an ALS assessment charge. So it might be a BLS level of service, but it's an ALS assessment charge added to it. Or in some markets, it may be an ALS level of service based on those three criteria being met. So what you heard earlier today would be true. And again, it's all because
Disagrees with what you said,
Well,
though.
that did.
I'm sorry, I can't hear you guys.
It disagrees with what you just said, though, correct?
So if there's an ALS EMD code, so again, chest pain, that'll be my example for the day. And an ALS provider was on scene, and that ALS provider did an ALS assessment, and it's documented. Obviously, if it's not documented, that's a different story. But if all three of those are met, but the care is BLS, because those first three criteria are met, you can give the ALS assessment charge.
Okay, thank you. We'd heard that earlier, I just wanted to make sure I heard it the same way. Thank
And I
you.
think it's ALS emergent, right? Because if you went emergently to that chest pain, because it was dispatched as an ALS emergent EMD code,
Mhm.
and then it was downgraded to BLS, it's still an ALS emergent, correct?
As long as there's an ALS provider who did an ALS assessment, then yes. If you've got that ALS EMD code and you responded, but you only had a BLS crew because it was downgraded, let's say, if they were downgraded and there was no paramedic, even though the original EMD code was ALS, then you wouldn't have an ALS assessment. And if you don't have one, then you can't bill it.
Thank you.
I'm sorry, I don't want to interrupt your presentation too
No,
much.
you're good.
I'm curious about the nuance, since we're in a changing world with EMTs.
Yep.
Are EMTs considered by CMS ALS?
Yes, they are. So anybody that's an AEMT or old school intermediate is considered ALS by CMS.
Great, thank you.
You bet. And sorry, because I can't quite see you guys, so please keep interrupting. That would be perfect.
We'll do it.
Sorry, Jen, this is great. Don't mean to.
Thank you.
No worries. I appreciate the questions. And like I said, good Lord, ALS assessment it's just a thing. So I don't want people to think that, hey, no matter what, because there was a paramedic on the unit, we're always going to bill ALS. That's not the case. There has to be those certain pieces of the puzzle that come together to actually use that ALS assessment. So it's not a straightforward and easy thing. The easy thing is when you do an ALS procedure, it's pretty straightforward. If you have a BLS EMD code, and even with the paramedic on the unit, if it's a BLS EMD code and there's no ALS care, then it's going to be BLS. So just because there's a medic on the unit doesn't automatically mean that it's going to be billed ALS. All right. So one thing that gets kind of frustrating, especially in the 911 world, not every trip is medically necessary. There are cases where it's just the cost of doing business. Maybe you're an exclusive provider and you have to respond to every 911 call and you have to respond to every interfacility transport. It's part of doing business. But even if you're the exclusive provider, it doesn't mean that every single call that you go on is going to be medically necessary. So it's really important to make sure that, again, there's quality clinical documentation, but it has to be accurate documentation. So just because, you know, there's that interfacility transport and the facility says, hey, you need to go to hospital A because we need you to, because the patient has, he fell 3 days ago and he's got some bruising and the doctor at the nursing home says he needs to go. So certain situations are going to be set up so that it may not be medically necessary, but if you're the exclusive provider, you may still have to transport. But in those cases, there's a little thing, especially with Medicare, where if the trip is not considered medically necessary for Medicare, we're only talking Medicare here, there's a thing called a GY modifier, and it's applied to that claim, and it means that we're billing Medicare for denial. I don't know how everybody's processes work. I don't know your billing companies. And so it's probably a good idea to get with your billing company to understand it further. But the way we process things is if there's no medical necessity on a transport, then the billing company will bill with the GY modifier, which I said is billing Medicare for denial. So we're telling Medicare, hey, we don't want you to pay us. We don't think there's medical necessity here. And so then Medicare is like, okay, it's a GY. I'm not going to pay. We're not going to pay for this trip. So when you know the trip is not medically necessary, billing for payment really is inappropriate. And that's why the GY modifier applies. There are other reasons for the GY modifier, things like non-covered services, specifically if we're transporting a patient from their home to a doctor's office, that's usually a non-covered service. And so it's going to be billed with a GY also. Like ALS assessment, GYs can be confusing. They can be just odd. If you have a third-party vendor and they're billing GYs and you're looking at the chart and you're like, this clearly has medical necessity, sometimes it's because the coders don't have that same level of understanding as you might as a clinician. So you reviewing the PCR may look at something thinking it's medically necessary while there's not clear documentation that points to that. The other problem that we run into from a clinician standpoint is you kind of get that feeling of, hey, well, it's a 911 call, so everything's going to be good, and I'm going to document this, and I know what's going on, but you forget that you know what's going on in your head, but you don't necessarily put that down in the paperwork. And so the crew, they think that they understand everything, they put everything in there, but the coder looks at it and says, I don't see medical necessity. And that's when we get back to quality clinical documentation is quality billing documentation. So make sure you're documenting everything appropriately, make sure you're documenting completely. And if you do good clinical documentation, then you're going to have good billing documentation. But even with that cost of doing business, it might still need to be billed with a GY because it just isn't medically necessary. And one thing to throw out there is the fact that just because it's a 911 call, 911 calls don't mean automatically that it's medically necessary. I'm sure all of you guys have examples of calls that you've run where you're like, oh my gosh, this guy did not need to go by ambulance. My favorite one way back when a patient called, he was at the YMCA playing basketball, jammed his pinky. Literally, that was what he did. He jammed his pinky. So I got there and I was like, okay, how's it going? What's going on? And he tells me, and I was like, okay, did you want to go by ambulance to the hospital? He's like, yeah. And I was like, okay. And he looks at me and he says, I have a stick shift. That's how long ago it was, you guys, because there aren't very many stick shifts out there anymore. Anyway, I was like, okay. And the reality is we transported him. He requested transport. But when you're sitting there and you're billing Medicare, it's a jammed pinky, and Medicare is going to look at it and say, no, I don't think so. And the reality is he probably could have been transported by other means. The one thing that I'll throw out there too is the definition of medical necessity, according to CMS, is looking at the patient and determining whether or not they could be transported by any other means without endangering their health or safety. If they can't be transported by any other means because it would be a danger to their health or safety, then an ambulance is appropriate. The guy who had his pinky jammed probably could have been transported by other means without endangering his health or safety. And so because of that, Medicare will look at that and say, oh, that's probably not medically necessary. And that would be a good trip that you would bill a GY. Does that make sense on the GY piece?
Yes.
It's another one of those crazy things like ALS assessment. So lastly, on the PCR, make sure that, again, quality clinical documentation, quality billing documentation, and realize that the PCR is your receipt or statement of work that you provided to the patient. So the services that you provided are going to be documented on that PCR. It's a receipt. That is literally the statement, the statement of work that you did, you provided for the patient. It's the primary document that billing uses to determine that level of service and for billing the trip. So I really started looking at things a little bit differently when I realized that my PCR is the primary document that the billing company is going to use. I'm the one that was on the scene. I'm the one that knows what happened. I'm the one that documented the care because I performed the care and I was around people who performed the care, or whatever the case is. But that's the only document that really tells you every piece of what's going on with that patient at the time of the encounter. So it's the receipt, it's that statement of work. And if you think about it like that, it makes it a little bit easier to really understand the billing piece of it. Because again, we're clinicians, and because we're clinicians, we went to school and we learned our trade, and we're providing services to these patients based on all the training that we had in the first place. So if you think about the fact that you're providing those services and your PCR is the receipt, then it makes it a little bit easier to understand why you need to have good clinical documentation, because that's going to lead to quality billing documentation. All right. So now let's talk about the big fun stuff that we need to get into, what to look for after the trip is billed. So just because that trip is billed doesn't mean that everything is done. You really need to watch that trip flow through all of the processes, all the way to payment, so you know from start to finish that that claim has been closed. So a few of the metrics. Days sales outstanding. That's always hard to say. I just call it DSO. But the days sales outstanding is the average number of days that it takes to receive payments from either the insurance company or the patient. And you really want to look at that because it really does help identify whether or not the trips are being billed timely, because many payers have a timely filing limit. Now, for Medicare, it's usually a year. Medicaid in Colorado, it's a year. Most of the other payers like Blue Cross, they may have a little bit of a longer time frame. But in general, we're talking about how to get those claims billed without it being an untimely bill, because if it's untimely, you're not going to receive any reimbursement for it. So the sooner you bill the trip, in theory, the sooner you're reimbursed. And that provides you with a steady flow of revenue, which is why it's really important to just monitor that DSO. I would say average numbers of DSO, it depends on the billing company. It depends on how quickly, again, how quickly claims are getting out the door. We're probably sitting at maybe a 40 to 50 day DSO. It just depends on the payer as well. So just watching your DSO to make sure that you don't have claims that are sitting out there forever and not getting billed out is an important number to check. So your net cash per trip, or your NCPT, that's how much reimbursement that you actually received for that trip. It's really what you get paid. It's not necessarily what you billed, because payers have the usual and customary rates, and that refers to how much they will actually pay for our services. But our services, I'm sure you guys know, our services are expensive. It's not a cheap thing to do. Running an ambulance, we have trained clinicians responding immediately to people in need. Our response not only has trained personnel, but we have ambulances and equipment, and we have all of that stuff to care for our patients. So being reimbursed is how we can keep our ability to serve our communities. If we aren't being reimbursed, how do we keep up with the sales of equipment? And how do we keep up with buying an ambulance? And how do we make a paycheck for our employees? It's really important to know that reimbursement is the way we keep running. So it's important to watch those trends with the net cash per trip, because it may be a clue to any payment issues that you may be having. The metric also identifies shifts in your ALS and BLS emergency and non-emergency work. So if you're used to having, let's say a 60% ALS mix, so 60% ALS and 40% BLS, and all of a sudden it's shifted to maybe a 50-50, you need to figure out what's going on. And it may very well be normal. It may be the situation that's at hand, but it may not be normal, and you want to dig into that and find out what's going on. One thing that really hit with COVID is we started sending a lot of BLS units out there because we didn't have ALS providers on all of our units. And so it just kind of changed everything, and it made a shift between the ALS and BLS payers, because all of a sudden you had more BLS units out there running calls, and they couldn't do ALS care for our patients, even if the patient needed ALS care. So we saw the shift in ALS and BLS, but it made sense. We knew what was happening. If you see a shift and you don't know why it's happening, you're going to have to dig in to figure out what's going on. It really does. This is a good metric to watch, because it does paint the picture of your revenue stream. Your AR, your accounts receivable, and usually we look at AR over 90. The numbers are important because it helps you identify those payers who reimburse quickly and those who don't. And there are several payers out there who, you know, they get the claim and they're like, okay, this looks good, we're going to go ahead and pay. And there's other ones who will fight tooth and nail. And I think we all can understand how sometimes paying for things just hurts. You know, inflation is crazy right now. And sometimes when you have to go to the grocery store, the amount is just higher than you expected and you're really frustrated with it, but you have to pay it. Some of the payers are similar in the sense that they don't want to have to pay it. It's frustrating. And so you have to watch the AR over 90 just so you can see which payers are reimbursing quickly, those who aren't, and what problems that you may have when you talk to the payers that are out there. One other thing to really look at with the AR over 90 are your facilities. So facilities who aren't reimbursing for contractual obligations, like the VA, who takes a long time to pay, you really can identify that by looking at your AR over 90. And watching those metrics helps you identify the areas that you need to look into and potentially reach out to. So you may have a facility who just, again, you go to the grocery store and it's outrageously priced. A facility who has a contract with you who needs to pay for a transport, they're feeling the same way. They're stressed. They're trying to make sure that their money is being well spent. And so they're maybe slow playing it a little bit, but you have to have the conversation with them. So just watch that AR over 90. And then if you need to have that conversation, go out and do that. So a couple of other things, we talked about the billing for denials, the GY modifier. As I said, there are trips that sometimes just need to be billed for denial. Most of the time, the GY modifier is a Medicare thing. It's just something that you need to really watch, because if you're seeing a lot of GYs out there, is it because you are truly taking patients who don't have medical necessity, they don't meet medical necessity criteria, or is it a system issue with documentation? You know, sometimes our crews get busy and maybe they're running 15 calls in a 12-hour shift and they don't have time to sit there and really get their documentation done. Sorry about that, dog in the background, apologies. So anyway, if you don't have good solid documentation because your crews are tired or they're working too hard or they just aren't able to get that information down on paper. I say paper, which again tells you how old I am. Maybe they don't have that ability to get it documented. Then it's something that you may need to look at from a system standpoint, or maybe you just have one crew member with the problem. So it's just something to really consider and look at, and it really helps you identify whether or not those GY trips are appropriate because you're running a lot of non-medically necessary calls, or if you've got other things to look into. Your write-offs, any questions?
No,
Okay. Write-offs need to be closely monitored. They may identify areas of weakness within your documentation or the billing process. This is kind of that same scenario as a GY. If a GY is being billed for denial, well, write-off may be because your trip was denied, maybe by another payer. And so you have to look at that to determine, is it a payer issue? Did we need to get an authorization for Medicaid? What's going on with this scenario? Or is it just weak documentation? So watching your write-offs will help you monitor those situations. But to also think about from a write-off perspective, you've got your John or Jane Doe patients, and they're very common in every system that's out there. But a lot of times the hospital may be able to identify the patient. Our crews may not know the info at the time of the call. We may have an unconscious patient, but we can always ask the hospital for updated information. And that helps us negate a write-off because if we don't have patient information, it may lead to a write-off, but with the hospital's updated information, it may not. Other write-offs include Medicaid write-offs, like I mentioned, with authorizations, timely filing write-offs, like we talked about a little bit ago. Bad address write-offs are pretty common. Sometimes we'll have a patient who gives us an address, but then the face sheet from the hospital maybe has an old address on it. And I don't know about you guys, but sometimes the billing company sees the old address and they think because it's on the face sheet, it's the right address. And so you run into problems because then you have a bad address and the trip does, or the statement doesn't even get to the patient in the first place. So making sure that we have the right information and making sure that it's clearly documented on the PCR and you've got quality clinical documentation, it'll lead to quality billing documentation. So those are kind of the biggies to look for after the trip has been billed. Do you guys have questions? Really, ultimately, it's that quality clinical documentation that really matters. And if you pay attention to the revenue results, then your revenue is how you provide exemplary services to your communities because you're able to provide those services. And especially with the patient advocacy thing, as we were talking about earlier, you can actually make a difference for your patients by doing what's needed for them, by having quality documentation, accurate, truthful, honest documentation, and then getting as much information as you can, including patient signatures, so that the process can flow easily down the system, and then the patient doesn't have to get involved on the back end. That's what patient advocacy is making sure that we're doing the right thing for the patient. So, questions?
questions in the room?
When you're getting the denials, I didn't really understand the terminology GY.
Mm-hmm.
When you rebill those back, do you fix the report and shoot them back? What percentage are they saying, okay, you got the right stuff in here? I mean, is it even worth the time?
So on a GY, and a little more context with the GY, for Medicare, they use modifiers, like that's how they identify what's going on with that call. So is this a residence to a hospital? That's an RH modifier. So then there's a secondary modifier, and that was the one if you're billing for denial, which is the GY. It's just their terminology in general. So if it gets billed GY because there's no medical necessity, and for some reason you get additional information, you get hospital discharge records, your crew comes in and says, oh, dang it, I forgot, I should have put this on the PCR, I didn't think about it at the time. If you have additional information that makes it medically necessary, you have to go through the appeal process. So you can't refile a claim with Medicare if you've billed GY, it has to be an appeal.
I get it. Thank you.
Mm-hmm.
A quick question. I think it's that same process you're talking about, but let's say our service has been missing a critical code modifier.
Mm-hmm.
The example would be our service is allowed to bill cost plus, which that code is B2. But let's say my revenue cycle hasn't been doing that for 3 months. Do you have to go back through an appeal process on 3 months worth of charts to try to get that that code on there? Is that even a thing?
So usually if it's an issue where it's not that you billed for denial, it's just that your claim was billed incorrectly, then you can file a corrected claim. But if you billed it initially for denial because you said there was no medical necessity, then they'll push for the appeal. That's how you manage those ones.
I understand. How long do you have to correct the bill? Do they have any language in there?
So in a corrected claim scenario, if the trip is denied, you have 120 days from that denial date. If it's a change to it because they perhaps didn't, let's say they billed BLS and it should have been ALS or your cost plus, as you were mentioning. If they didn't file the claim appropriately, it's still within a year that they have the ability to file the claim. So as long as you're following timely filing parameters, you should be good.
Okay. Thank you.
Mhm.
Other questions? Any questions online? Not seeing any, Jim, but I have a couple.
Okay.
What should be a standard for the number of days to get a bill submitted for payment?
Great question. Usually, well, here's what I'm going to say for usually, and this is really based on how our side does it on the AMR side. So usually it takes about 2 days to get the claim from the crew's hands over to the coder's hands. So that's about a 1.5 to 2 day window. And then usually it's maybe a day, maybe 2 days to get that trip actually billed out. So usually less than 5 days is what we look at to get the claim billed.
And you, obviously, you only are really familiar with your process. Do you believe that to be an appropriate time frame if I've got a contract biller, if I'm doing it in-house, whatever? Is that a common time frame to get it done?
I would say that it's common and I would say that it's pretty reasonable. I think that there are times where it can be a little faster, especially if you're doing in-house billing. With in-house, that trip is getting straight over to the coder as quickly as possible. And so they may be able to turn it around a little quicker. On our side, we've got different processes. It flows through a couple of different channels before it gets to the coder, and then the coder will process it. And sometimes on the back end with the coder, depends on how that trip is. For example, if we GY a trip on our side, the coder GYs the trip. Well, it has to go through a QA process at the billing vendor's level. So the coder GYs it, and then they do a QA on it to make sure that GY is correct. And then if it is correct, they bill it. If it's not correct, they give it back to the coder. So that's going to eat up a day or two as well. So I think it depends on your market. It depends on if it's third-party vendor billing, if it's in-house, a lot of variables, but I think 5 days is pretty good, really.
Thank you.
Mhm.
How does this relate to the DSO then? The 5 days to get it submitted, and then the DSO was the number of days till you got cash back, correct?
Yes, and so that 5 days is going to sit on top of however many other days it takes to get reimbursed.
And you want your DSO to be between 40 and 50.
That's a good DSO. Usually we've seen it jump up higher. A lot of times it'll jump up higher because of the time that it takes to get the trip billed out. Another reason it may go up higher, again, VA, if anybody's had to worry about VA billing, you know that it takes quite a while. So you can look at your different payers and see, okay, VA is going to take 84 days and Medicare is going to take 48 days or whatever. So looking at the individual payers helps, but in general, 50 or so average is probably pretty good.
Okay. Any questions? Okay. I'm gonna hit a couple more for me
No, it's
then.
great. I love it. Keep going.
At what point do you just write it off, a bill? Tim was talking earlier about his, I can't even remember the number he used, but he got a total of $4,000 back on what was it?
Oh, it's $500,000.
It was $500,000 in bad debt,
Write-offs, yeah.
but through collections, he'd only gotten $4,000. At
Mhm.
what point would you recommend just saying, how many days do you just give up?
You know, that's a great question. I may have a difference of opinion between maybe the third party billing vendor and maybe my boss. I don't know. I feel pretty strongly about making sure that we've got quality clinical documentation. And if we do, then I try to make sure that we're doing what's best for the patient. So from a write-off perspective, we take it kind of a long way. It depends on the payer, obviously. That's always going to be something that we have to deal with. Sometimes we've seen things get sent to collections within 6 months. Sometimes dependent on the payer, it might be a little sooner. I don't have a great solid answer for you because it varies from location to location, and it varies from payer to payer, and it just varies on what the situation is to begin with. So how's that for a crappy answer?
I'm gonna follow it up with another crappy question. Online, would you describe the pros, cons of writing off the account at the time it goes to the collection agency versus sometime after it's been at collections for a while?
So usually if it goes to collections, we zero out on our side, and then it's going to sit with collections on their side.
And so if you then did get anything back, that's just gonna be a little bit of bonus then.
It ends up being kind of, for lack of a better phrase, reopened, I guess, and then we apply it to that account on our side. But I mean, really, it's a little bit of a, I guess, increase a little bit of an amount coming over from the collections agency. They pretty
Okay,
much own the account once we turn it over to them.
Jason, I hope that helped a little bit. If you'd like to follow up, go ahead. Tim has a question.
Not necessarily, but a follow-up and see if Jen actually agrees with this. If you're sending something out to collections because it's highly uncollectible while it stays on your books, if you leave it on your books, then you're overstating your AR.
Right,
And that's one of the things you don't want to do.
right.
Do you agree, Jen?
I do agree. I don't think overstating your AR is a good idea. So keeping accounts, bad accounts on the books for a long time is not a healthy way to approach things. So it's definitely one of those things you have to look at. And like I mentioned a minute ago, there's so many variables that you have to pay attention to. Again, payers, and even if it's just, maybe it's a situation where you've got a patient who has called in and wants to do a payment plan, and they can only afford $10 a month, but they are just adamant about paying you $10 a month. Well, you work with that patient. I actually had a long time ago somebody who felt that, okay, well, they're only paying $10 a month, and so we're going to send them to collections. And in my opinion, you've got those patients, especially our older generations, where they will pay their bills, by God, they will make sure it's taken care of. And if they are making an attempt to do so, then I wouldn't call it bad debt. They're trying to make it happen. Now, others may disagree with me on the bad debt piece, but I think if somebody's trying to do it, if they're trying to make it right, if they're trying to pay for their services that they received, then go with it. I don't know if that helped, Tim.
I think he got what he wanted. Here's another one from online. What about writing off accounts where the payer refuses communication of any kind with you about an account after multiple attempts, and now the accounts are almost a year past due?
Then it depends on a couple of other things, unfortunately. So you've got scenarios where the payer just won't engage with you, and maybe that payer is, okay, Blue Cross or something like that, and or maybe if it's a facility contract, that's a little bit different of a scenario because they are supposedly contracted with you to pay for that bill. So they should be engaging with you on that. And sometimes if they're not, then you may have to take more drastic steps with them, including maybe you're going to the far reaches of the world where you're sitting there saying, you know what, if you're not going to pay, we have a contract for it. So we're going to have to take this up legally or something like that. If you've got a payer who just won't respond to you at all, depending again on the situation, you may have to get the patient involved. We've had a lot of scenarios where maybe Blue Cross or whoever, doesn't, for whatever reason, they keep denying the claim. And when they do, it ends up being the patient's responsibility. So the expectation, unfortunately, would be that the patient engage with Blue Cross so that they can work through that situation. And so it might be a scenario where you have the patient engage with them. It might be a situation where it doesn't matter, it's just never going to happen, and you might end up writing it off. Everything's going to be totally dependent on the situation.
Okay, thank you. Any other questions? Looks like we're kind of quiet here in the room, and I don't see any more online. Jen, you've done a great job answering at least some of my questions. I don't guess I know exactly what constitutes a good billing service. I'll continue to try to figure that out over time. So I appreciate your time today, and thank you for everything.
Well, you're welcome. And if I can just leave one last nugget, good clinical documentation is good quality billing documentation. And just make sure, no matter what, that you've got good, clean, honest, thorough documentation, and that should usually get you through the process.
Very good.
All right,
Thanks,
guys.
Jen.
Thank you.